Dr. Vinayak, please, and I'll request for the Dr. Ajay Jindal, please, to chair the session, and Dr. Rajesh Nandal to please come and chair the session, and Dr. SSOD, please. Dr. SSOD is a non-invasive and invasive cardiologist, Mohali, very active in social media, very good singer, and president of IMA, and so many other things. Dr. Rajesh Nandal is in Mulana Hospital. He is an intervention cardiology person, and they have their own DM student, so he's a teacher as well. Dr. Vinayak, I think he has already been presented to the house, and for the sake of the time, I think we would start with the presentation.
Thank you, Dr. UP Singh, for inviting me to such an enlightening conference. Just to, remind that we, Dr. J.C. Mohan, me and Dr. Madhu, we conduct an Echo Daily program, which is a 2-day program very similar to this. And we've been doing that for 15 years. Those who have been part of it are most welcome to join us on March 14th and 15th, 2026 in Delhi at Lee Meridian Hotel. So today I'm going to be talking about a very, very important topic, which is how to approach a patient who has a left ventricular wall thickening and comes to you in your clinical practice. Now, there is a change in the concept of how we look at so-called cardiomyopathies. So a lot of people tend to write any significant thickening as hypertrophic cardiomyopathy or HCM the moment you find significant hypertrophy, asymmetrical hypertrophy. And we have to understand that in the last 2 to 3 years, there is a sea change in the way we look at so-called cardiomyopathy and its diagnosis. So the entire approach is now based on the phenotypic identification of a muscle defect. It can be hypertrophy, dilatation, or a non-dilated subset. But you look at that phenotype, and you also look at what is known as the phenocopies. So something which looks like a hypertrophic cardiomyopathy, but is not HCM. And the other is to look at the risk of that particular entity. So you risk stratify based on not just the clinical picture, but on initially ECG, echo, and then more advanced cardiac imaging like cardiac MR, PET, and wherever required, you do the angiogram, CT angios, etc. And of course, in selected cases, bone scintigraphy, like as an ATTR amyloid. So the change is that you look at the clinical scenarios, how the patient is presenting. Some patients may present with dyspnea, some with angina, some may present with syncope, sudden cardiac death survivors, and they may have significant family history of sudden cardiac death. Then you move on to the morphological or functional characteristics of this individual to suspect cardiomyopathy. And you look at the dilatation, hypertrophy, systolic or diastolic dysfunction. You look at the ischemic or non-ischemic scar. And then the various phenotypes, which can be hypertrophic cardiomyopathy, dilated cardiomyopathy, ARVC, restrictive cardiomyopathy, and non-dilated left ventricular cardiomyopathy. Added to that would be the arrhythmic potential or the potential for AV blocks, etc. And what you get in the end is a phenotypic-based integrated etiological diagnosis. So when we describe the phenotypes, we're looking at the ventricular hypertrophy in the right or left or both, dilatation, scar, ischemic, non-ischemic scars, characteristic features on MR, CMR. And to give you an idea, if you look at the characterization based on CMR, you can have hypertrophic cardiomyopathy, where you can have the uh, you have a posterolateral LG scar, which looks like, which you commonly see in Fabry or Anderson-Fabry disease. You have a diffuse subendocardial LG with high T1 values, which is characteristic of amyloid, and of course, patchy wall involvement as in suspected HCM. Similarly, in DCM and other types of cardiomyopathies, for example, in NDLC, you see this ring-like structure, which is very common in the desmoplakin and FLNC, etc. variants. So this sort of a characteristic LG pattern can help you to identify patients of different cardiomyopathies. The new guidelines in 2023 in ESC have basically proposed some innovations like actual myocardial tissue characterization traits, the ventricular scars, and fatty replacement. There is this new entity which is NDL, which is non-dilated LV cardiomyopathy, and the atrial dilatation of both left or right atria, both is very important because you can have an isolated atrial cardiomyopathies as well, which is important to distinguish these as part of cardiomyopathy spectrum. So this is an example of how you probably would be categorizing the cardiomyopathies. You have a 17-year-old male with a family history of sudden cardiac death with normal physical examination comes to you, you do an echo and an MR, you find a non-dilated LV EF of 55 with a subepicardial scar. Now, when you look at the Holter and the ECG, you see a minor intraventricular conduction delays, few VPCs, and you do a genetic testing and you find desmoplakin mutation. So the previous classification would have been a dilated cardiomyopathy substrate with ALVC with arrhythmogenic cardiomyopathy. But the new classification will be an autosomal dominant desmoplakin related NDLVC phenotype with subepicardial scar with no low normal EF. Now, this is how we are changing the way we approach cardiomyopathies, where we look at not just the morphological or phenotype, but the impact of it. So you are looking into a multimodality imaging, including cardiogenetics, to help you out with stratification. So the stratification in this 17-year-old, almost normal looking individual will drastically change after the CMR and the cardiogenetic testing. So this is how we approach the present day generation cardiomyopathy. Now, when we look at a thick LV wall, we look at whether it is, as I said, true HCM, phenocopy, or a phenocopy, a focal or diffuse, symmetrical, asymmetrical, or concentric hypertrophy, obstructive or non-obstructive, associated mitral and other valvular abnormalities, and LA dilatation. Now, to understand hypertrophy, we have to understand the components of the LV muscle. So the myocyte actually has all these components where you have the actin myosin, which are interdigitizing themselves and contracting with each contraction. There is a sliding of these actin and myosin fibers. Then you have the Z disc, which is basically anchoring these myocytes. And then you have in between the microtubules and desmin, which provide the strength, the microtubules which provide strength to the muscle fiber. This is akin to what we call as an earth, when you create earthquake resistant buildings, the myocardium also fortifies itself under duress, under strain, whenever there is an increased strain, whether it is hypercontractility, high blood pressure, hypertension, etc. So what it does is, especially the interventricular septum in hypertrophic cardiomyopathy, would generate viscoelastic control dampers. So will be an increase in microtubule densification. There will be detyrosination, desmin and myofibril or myotubule intensification or deposition. There's going to be thickening of the muscle as the stress goes up on the muscle. So based on, when you look at somebody who comes to you with hypertrophy, you have to look at adaptive LV hypertrophy. So you have an athletic heart, which person is, an endurance athlete, you would have hypertrophy in them, but that would be a physiological or adaptive hypertrophy. You can have secondary hypertrophy, secondary to hypertension, aortic stenosis, pregnancies, CKD, valvular heart disease, etc., like AS, then you can have the LV wall may look thickened. For example, the mural thickening can occur because of a thrombus or a mass or a tumor, and sometimes intramyocardial hemorrhage or IMH. But the true non-adaptive or maladaptive LV hypertrophy would include hypertrophic cardiomyopathy. We've already had a talk on that. And then you have infiltrative, like you have the amyloid, both the AL and the ATTR variety, and you have the Fabry's disease. These are the common variants. If you want the entire list of it, you can actually look at the possibilities of hereditary oxaluria, hemochromatosis with iron deposition, Friedreich's ataxia, Dannon's, etc., mucopolysaccharidosis. So the endocrinopathies can also give rise to left ventricular hypertrophy. Now, whenever you have an LV thickness which is more than 15 millimeter, the chances are that you're looking at a sarcomeric or hypertrophic cardiomyopathy substrate. If you have a family history of hypertrophic cardiomyopathy and yet one of the first degree relatives has 13 millimeter thickening of the muscle, that can also pinpoint to hypertrophic cardiomyopathy. So what are the things which are not sarcomeric or non-hypertrophic cardiomyopathy substrate? So one will be an elongated mitral valve. We know that 50% of HCM patients would have some mitral valve abnormality or mitral apparatus abnormality. So you may have an elongated mitral valve. They may have microcirculatory disease. So they may present with angina, fibrosis, which is significant scars, apical aneurysm. You have the anomalous papillary muscle attachments. You can have regional or focal hypertrophies are possible in HCM. And you can also have some other features like, uh, you know, the apicoseptal muscle bundles or hypertrophic muscle bundles. Myocardial crypts are important. They can be seen in normal hyper LVH patients, hypertensive patients, but are much smaller and narrower. But when you see significant prominent crypts, that may signify HCM. And of course, paradoxical longitudinal strain, which is more pronounced as septum. All these can focus you on the possibility of a sarcomeric hypertrophic cardiomyopathy. The phenotype is also important. So you have the reverse curvature, the sigmoid curvature, neutral curvature. Then you can have an apical HCM and a mid-cavity variant. Now, why is it important? So if you look at the HCM, I'm sure it has been talked about. So when you have a reverse, so normal curvature is concave. If you have, say, when you look at the reverse curvature, it can be mild. Here, if you look at it, is quite convex. And here you have just a sigmoid. So these variants are there. What is the importance of them? So if you look at the sigmoidal, the chance that it would be genetic in origin or sarcomeric in origin is extremely low, 10 to 20%. When you look at the convex, the chances are 80 to 90% chance that you're looking at a true hypertrophic cardiomyopathy. If you're looking at apical, again, about 40% chance, and neutral is around 40% also. So how the septum looks is important in trying to gauge whether you're looking at a genetically determined or a phenotypically determined entity. So this is an example of hypertrophic cardiomyopathy patients with apical hypertrophy, presented with apical hypertrophy, but had an aneurysm at the top. Now, you can clearly see that there was an apical hypertrophy and now there is an aneurysm. You can actually see a clot here. Similar picture. Now, when you look at somebody with apical hypertrophy, we have been traditionally taught that it is a benign entity. But you have to try and see which substrate of apical hypertrophy can actually lead to sudden cardiac death or have, say, a worse prognosis. So if you have a marked T wave inversions in only the lateral precordial leads, you don't have apical LVH you have a contrast CMR which does not show any LG, the chances are you're looking at a lower risk. If you see a diffuse T wave inversion throughout the ECG, if there is apical or thin walled aneurysm at the top, at the apex, you have an LG scar, then the chances of sudden cardiac death increases. The recent study, which was published in JACC in 2025, actually had 462 patients of apical HCM, And what they found out, they actually had a score system. And in that, if you had apical aneurysm, that was one of the features for high risk. Age, as the age advances, the risk went up. If you had larvae more than 34, more than 48, it was high risk. So more the LA enlargement, more is the risk. And the other one was the creatinine levels of more than 1.4 and RV pressures of more than 50. So these were the criteria based on which they identified the risk, and overall risk of composite event was about 3% per year. Now, in the infiltrative cardiomyopathies, we normally talk about the two most important that we talk about are amyloidosis and Anderson Fabry disease. I'm going to show you some case related to that. I'm not going to touch upon everything, but this is a list of infiltrative cardiomyopathies that one can go through. So cardiac amyloid is nothing but there is misfolding or monomer folding of transthyretin or monoclonal proliferation of certain proteins, plasma cell dyscrasia, which can lead to AL type, or if it is transthyretin, it can lead to ATTR variety of amyloidosis. So you can have an AL, which is a plasma cell proliferation of either the kappa or the lambda light chains. You can have a wild or a variant type of ATTR amyloid. So whenever you have an unexplained LVH with restrictive filling, you must think about infiltrative cardiomyopathies. They can present with raccoon eyes. The classical picture which we are all used to is something like this, where you have a granular or sparkling appearance of the LV wall with more than 15 millimeter of thickness. So you can see very classical picture of small pericardial effusion. Patient has some granular sparkling appearance of the myocardium. Similarly, owl eye appearance because of large atria and thickened valves because of valvulopathy. You can have so this is the strain pattern which I'm going to show you. Right ventricular hypertrophy can come, interatrial septal thickening can occur, and this typical cherry on top appearance with LG of just -4 percent is there, the GLS, the global with apical sparing. So whenever you have LVH, RVH, and atrial septal thickening, you must think about infiltrative myopathy, especially cardiac amyloid. Now, the apical sparing which you see in LG pattern is not specific to amyloid. It can occur in hypertrophic cardiomyopathy, hypertensive heart disease, aortic stenosis, CKD, and CAD also. So it is not specific to that, but it can hint towards amyloid. So this is one case, 54-year-old lady, hypertensive, with easy fatigability, pedal edema, and dyspnea on exertion. She had a rapidly progressive renal dysfunction, so creatinine rose up to 4.4 very quickly within 3 months or so. All her testing was negative, ANCA and other connective tissue disorder testing was negative. There was proteinuria, and this ECG was classical. There was, and I'm going to show you the echo, there was left ventricular hypertrophy, but there was discordance between the ECG and the LV hypertrophy. So this was the left ventricular hypertrophy. You can see it's not marked hypertrophy, but there is an asymmetrical hypertrophy which is there with some mild MR. Again, you can see there is diffuse, almost concentric hypertrophy. All the views there. You had significant TR with the PA pressure about 33 plus CVP was about 15, so about 50 PA pressures. And again, you had that typical apical sparing on LG. So the LVEF to LG ratio was more than 4. The bullseye pattern was there, and the apical strain to mid-basal strain ratio was more than 3:1, all pointing towards possibility of amyloid. And this is just to give you an idea. So LG, the amyloid, we usually have this apical sparing in the middle. If you look at the possibility of other septal, asymmetrical septal hypertrophy in HCM, you can have a diffuse involvement or just the involvement of the septum where the LG goes down, or you can have patchy LVH as in aortic stenosis. So LG patterns can differ, but by and large, some of the patterns can be suggestive. The LA strain was markedly reduced, so was the RV strain, free wall strain was mildly reduced. And you had the typical 555 sign on tissue Doppler, where the E prime was less than 5, A prime was less than 5, and the TSV was also less than 5. The S wave was less than 5, not the RV. So E prime, A prime, and the S wave were all less than 5. So the LV mass was increased, LAVI was increased to about 35, and this was the free light chain assays, which the ratio was actually not abnormal. It was pretty much normal. There was slight increase in both the kappa and the lambda, which is quite common in CKD substrate. But what you can see is the NT-proBNP is disproportionately increased to about 20,000 or so. When we did so with the suspicion of amyloid, we went ahead with the renal biopsy, and it was suggestive of amyloidosis. But please remember, at this point in time, we are not sure which kind of amyloid are we looking at. We did the fat pad biopsy, which was actually negative. We went ahead and did the bone marrow biopsy, which showed both kappa and lambda positive plasma cells. So here you're caught up. Now you don't know which kind of amyloid are we looking at, kappa or lambda restricted. But there was no doubt that there was amyloidosis because of the eosinophilic amyloid deposit with apple green birefringence. So we went ahead and did the cardiac MRI, which showed markedly elevated T1 values of around 1100. Normal T1 would be somewhere around 950 to 1050 or so. ECV was also markedly increased to 61%, and there was myocardial suppression before the blood pool suppression, highly suggestive of amyloid. So then we had no other choice but to do the mass spectrophotometry, which eventually clinched the diagnosis of AL amyloid. So this is how we approach these patients of hypertrophy, looking at each and everything and doing what is required to diagnose these cases. So this is the typical subepicardial LG pattern, both in atria and LV. You can have a transmural pattern. You can have markedly increased T1 values in this case. And the recent meta-analysis of around 2,000 patients showed that if you have elevated ECV, that is the highest hazard ratio of nearly 4. LG extent, native T1 increase, reduced GLS, and reduced GF all are suggestive of high mortality in these cases. And there are many algorithms. You can either do initial echo followed by protein electrophoresis, FLC, etc. Initially, you can. So Germans actually do cardiac MRI first, and then others later. Some like the Americans do the monoclonal protein pathways first, while the Japanese and the Europeans tend to do scintigraphy and the monoclonal protein first. So it depends on which you try and do in your clinical practice. Now, moving forward to Fabry's disease quickly, again, as I said, that whenever you see a thickened myocardium, one of the possibilities can be Fabry's disease. And the differential diagnoses are exactly what we had told you in the beginning. And here, what you have to understand is you have history of childhood neuropathic pains, abdominal cramps, diarrhea, hyperhidrosis, fatigue, depression, etc. Family history may be suggestive, including sudden cardiac death and cardiomyopathy. And on examination, you can have some physical things like you have early stroke TIAs, hearing loss, you can have the corneal vortex keratopathy, which you also see in an imidazole toxicity, angiokeratomas, like which we have shown, and features of neuropathy, etc. But it is often very misdiagnosed or completely missed because we're not even thinking about it. And when you look at an ECG like this, amyloid ECGs tend to be discordant. But when you look at a Fabry's disease ECG, you can actually have very similar to our Yamaguchi picture, where very deep T inversions can be there with LVH. And this is a case of Fabry's disease. Looks like any other cardiomyopathy, including hypertrophic cardiomyopathy. Look at the papillary muscles, which are very prominent here. And I want you to pay attention to the septum here. Just look at this septum here. Okay. Submid ventricular gradients. So it can have increased wall thickness, and because of the glycolipid deposition, there is ventricular muscle thickening, including papillary muscle thickening. Usually concentric LVH is there, but it can have ASH. So I'm just going to show you what is important when you're looking at something like this. So the classical picture was known as the binary sign, where you had an hyperechogenic endocardial surface and hypoechogenic subendocardial layer. So the subendocardial layer was actually hypoechogenic, while the endocardial layer was hyperechogenic. And this was because the subendocardial space had glycosphingolipids. So this kind of a binary sign, but has a lot of specificity of about 80%, but only 28% sensitivity. You can have prominent papillary muscles, which are thickened and hyperechogenic. They can, and what it can distinguish is in HCM, you tend to have more of mitral valve and papillary muscle abnormalities. The other very important thing is the thinning of LV basal, posterior, and lateral segments. So this kind of a thinning, if you find in any patient with hypertrophy, you should always suspect a possibility of Anderson-Fabry disease. So what you can see is the lateral and posterior wall segments show a reduction in the strain. You can have this typical picture on LGE or LG on the strain curve. So you can see this is the posterolateral part, which is scarred or involved here. And the cardiac MRI is important because it picks up there is a very important distinction between amyloid and Fabry is because of the increased extracellular volume and sphingolipid deposition, the T1 values are extremely low or much lower in the Fabry's disease as compared to amyloid. Amyloid will have high T1 and high ECV, while Fabry will have low T1 and high ECV. So that's one of the most important distinguishing features. And the usual numbers are about 900 to 950, 980 is what you see in Fabry's as compared to amyloid, which can have about 1100 or so or more. So this is the typical basal infralateral LG. You can have a markedly reduced T1 values and elevated T2 values because of the edema and ECV increase. And of course, you have the enzyme replacement therapy, which is highly effective. So it's important to pick these up early by having a higher degree of suspicion. The last word is about non-compaction versus excessive trabeculations, which can present like hypertrophy or focal hypertrophies. Nowadays, we are not calling excessive trabeculations as non-compaction. In fact, the right term to use is ET or excessive trabeculations. You can find these excessive trabeculations in athletes, pregnant women, thalassemia, aortic regurgitation, CKD, chemotherapy, or sickle cell anemia. And it can be present as a part of normal variant. So the clinical management should not be determined by the pattern of the trabeculations. So this is an example of excessive trabeculations. You can see that the apex and lateral wall have excessive trabeculations. This is a similar picture. You can see that there is significant hypertrabeculation on the apical and lateral wall. Same shown on the MRI. Then athlete's heart is also similar, but the clinical picture will be very, very suggestive. There will be no LG. The native T1 ECV values will be normal in most cases, though the LA, LV both can be enlarged and so can be RARV. So on an average, you are looking at, whenever you approach a patient of hypertrophy, please remember that you have to keep in mind all these factors that we have discussed and then make your diagnosis. Thank you.
An excellent talk, Dr. Vinayak. So an important message that LVH by itself is not a complete diagnosis. We should try to find out what are the cause of that LVH. So we have to investigate accordingly. Excellent academic session today. Any questions, please?
I think on MRI, you should also add what is the amount of LV mass involved, the scar tissue, because that also predicts the prognosis of the. So I think that should be done.
No, absolutely.
If it is more than 15, it's not a very good prognosis. So I think that should be mentioned.
Yeah, it helps you to for risk stratification, for example, if it is 15% or more, chances are that you would probably give an ICD in such cases of hypertrophic cardiomyopathy, and looking at the others, say, score for risk stratification. But the idea is to not just rely on your clinical picture and echo. I think we have to move into multimodality imaging now. Cardiac MRI is indispensable in today's age.
यार एक चीज नहीं समझ में आई.
Sir,
There was one score which you showed in which you said that in hypertrophic cardiomyopathy, age more than 80 has a score of 3. I thought it should be in younger crowd.
the apical.
Oh, it
That was an
only for
apical.
Okay.
In hypertrophic cardiomyopathy, the risk goes down with age of sudden cardiac death. In
Correct.
HCM.
Correct. That's the reason, because history of sudden cardiac death, early detection, those are things. Correct. Thanks.
Sir, in sarcoidosis also there is a scarring and hypokinesia. Like
Yeah.
every disease.
Yeah, sarcoid, of course, it's one of the most important, say, distinguishing features that we. You mean in cardiac MRI?
No, how you differentiate between febrile and sarcoidosis?
Hypertroph versus thinning.
No, you can have hypertrophy, but it is mostly the scarring which is pathognomonic, which is your
Thinning is-
basal anterior septum, and you can have apical aneurysms, you can have patchy involvement of the myocardium. Then I think then cardiac MRI is very, very important. So is the FDG PET. So FDG PET is important for, say, treatment-related decision-making, how much activity is there. Cardiac MRI for actually looking at the classical granulomatous appearance for diagnosis, as well as the amount of scarring that you have. Because that can also be important for taking a call on your ICD in some of these cases. So,
Recent article on 1 month back, either in JSC or JSC cardiovascular imaging,
sir,
on a mid-ventricular hypertrophy. They said you measure a distance between the anterior papillary muscle and the other wall. The shortest the distance, they proved by studies, the poorer the prognosis and the more the chances of a sudden cardiac death and apical aneurysm. And by some management cases, once the distance increased, the gradient came down and the prognosis. I think that is one very interesting article. I think you should read on that, mid-ventricular hypertrophy and this relation of the distance between the anterior papillary muscle and that.
sure, sir.
Wonderful. I think we would have to call it a day, and sorry for the session. We would have a lunch, and please don't go anywhere. The poker, the cases, eco cases are going to be immediately after lunch. Okay, they'll be giving you a rapid fire cases with explanations, of course, but your involvement would be very, very important.